I'm Dr. Margaret Lafferty, live from the 2017 Hot Topics in Neonatology Conference in Washington, D.C. I'm joined by Dr. Robin Steinhorn from Children's National, and we're here to discuss her talk on BPD-associated pulmonary hypertension. Welcome, Dr. Steinhorn.
Thank you.
Thank you so much for being here. Can you tell us what was the main objective of your talk?
Well, I think in my talk, with the brief time I had, was to increase awareness of how common pulmonary hypertension is in preterm babies, both early in those babies that have severe hypoxemic respiratory failure, and later on associated with their bronchopulmonary dysplasia.
To follow up, how common is it in these preterm babies?
So in preterm babies, about 2% of them will have significant pulmonary hypertension in the first week of life. Some so significant that it is life-threatening, and detecting it and treating it can be life-saving. More commonly, though, we see pulmonary hypertension associated with bronchopulmonary dysplasia when it's diagnosed at 36 weeks postmenstrual age. And in that population, in particular those babies that have moderate or severe BPD, we'll see pulmonary hypertension in anywhere from 10 to 40% of those infants.
How would you say is the best way to detect this pulmonary hypertension in the early onset group, these preemies who get it early?
So the answer would be the same for both groups, and I think it would be two things. First is being aware that this condition exists, and because you're not going to find what you don't look for, the best way to screen is with a cardiac echo. Now you have to really work with your cardiology team because pulmonary hypertension can be diagnosed with a tricuspid regurgitant jet, sort of that traditional way, but there are other more subtle signs. Septal flattening, right ventricular hypertrophy, right ventricular dilation can also be signs of pulmonary hypertension. This early group can also be important because what Pete Morani and Steve Abman have showed us is that if we see pulmonary hypertension, even these subtle signs in that first week of life, it's a powerful predictor of later lung disease and later pulmonary hypertension.
And if we diagnose pulmonary hypertension in these preemie babies, in your opinion, what's the best way to treat this pulmonary hypertension?
Great question, and one that we really don't have good answers for. In the first few days of life, if you have a preterm baby who doesn't have much parenchymal lung disease, or you've treated it and the lung looks fine, and that baby still has life-threatening hypoxemia, our recommendation would be to give a brief course of inhaled nitric oxide. We know that 90% of the babies will respond with an improvement in oxygenation, and survival is about 80% in what is clearly a very high risk, very ill population. What we don't really know is later on in that child who has BPD-associated pulmonary hypertension, what is the best course of treatment. We do recommend considering treatment for babies who have significant pH, so pulmonary arterial pressure that is more than half, often more than 2/3 systemic, starting with monotherapy. Sildenafil, bosentan tend to be the two most common choices. But what we don't know is the length of therapy, and none of this has been optimized yet through randomized trials.
That's true. What would you say, Dr. Steinhorn, is the overall main point that you would like the audience to take away from your talk?
So I think there's a couple of points, is to tune your eye to the possibility of pulmonary hypertension. The preterm lung is disrupted not only in its parenchymal development, but in its vascular development as well. And so this is a very high-risk population. I think to consider pulmonary hypertension as a cause of hypoxemia, both early and late. And third, to remember this is a team sport. That in particular, these children with severe BPD, you're going to need a team that is very expert, not only in the lung support, but the pulmonary vascular support. So a cardiologist, ideally one that has expertise in pulmonary hypertension.
That's great. And how about, I know there's a lot we don't know about pulmonary hypertension in the preemie population, so where do we go from here?
Well, my hope is that increased awareness will inspire our community to come together and do the trials we most need. To me, it's pretty shocking that of all the drugs that are available for pulmonary hypertension, only one is approved in children at all, and that's bosentan. So developing that evidence base for what drugs we should use and when for children who clearly are at high risk, I think that's a really important problem to solve, and I hope the neonatologists here will participate in trials when they begin.
Absolutely. Well, thank you very much, Dr. Steinhorn. That's a wrap. We are here live at the 2017 Hot Topics in Neonatology Conference in Washington, D.C.